This lecture addresses some topics in the respiratory system, namely neonatal respiratory distress syndrome, which may occur if the lungs aren't fully developed. It typically occurs in premature babies. For neonatal respiratory distress syndrome, since this will show up on step 1, but also after that on the OBGYN shelf exam, we can mention that term birth is between 37 and 42 weeks, and any delivery before 37 weeks is considered preterm, and the baby thus delivered is considered premature. Because of the timing of the saccular and alveolar stages of lung development, prematurity is associated with lung underdevelopment. One of the major issues underlying NRDS is insufficient surfactant to keep the alveoli from collapsing entirely. So it has this in common with ARDS, which otherwise known as acute respiratory distress syndrome. When the patient has already started labor, we can try to give tocolytics to try to slow things down, not because we expect to delay delivery enough to make it to term. Rather, we just want enough time to give the patient steroids to promote fetal lung maturation. Maybe then we can prevent or at least reduce the severity of neonatal respiratory distress syndrome. Any labor after 42 weeks is post-term, and any before 37 weeks is preterm. In the case of preterm labor, we should give tocolytics. Brief point about the word tocolytic: the tokos part in Greek is about childbirth, and we can take the lytic part simply to mean trying to go against or trying to oppose. So tocolytic literally means trying to stop childbirth. The same root actually shows up in pitocin, which is the synthetic form of oxytocin. Oxytocin is one of the 2 hormones produced in the hypothalamus and released by the posterior pituitary. It would have been easier to recognize tocolytic and oxytocin as cognates if they had decided to pronounce it oxytocin. Incidentally, I ran across a 2011 journal article whose title made me laugh. It was called The Orgasmic History of Oxytocin: Love, Lust, and Labor. Anyway, those are some of the various functions of oxytocin, or normal pronunciation oxytocin. And labor is about increased uterine tone. Since one of the numerous functions of beta-2 adrenergic receptors is decrease in uterine tone, one possible tocolytic is terbutaline, which is a direct sympathomimetic with more beta-2 than beta-1 effects. By the way, that means it will work, as do albuterol and salmeterol. It will work for asthma as well. Terbutaline will work for asthma. So terbutaline, a direct sympathomimetic, specifically a beta-2 agonist, decreases uterine tone. It can be thus used as a tocolytic to slightly slow down preterm labor, to give steroids to promote fetal lung maturation. Now, without getting into it too much, let's make sure we know that there are other tocolytics and that the decision of which to use is related to how many weeks gestation. I'm thinking of nifedipine and indomethacin. Hopefully, when I ask what class indomethacin is, it's easy for you to answer. NSAID. And then nifedipine, ending in dipine, is a calcium channel blocker. Good. And then more specific than that, a dihydropyridine calcium channel blocker. So for dipines, we think more of smooth muscle and vascular effects. So terbutaline, nifedipine, and indomethacin can be employed as tocolytics to slow down labor, because prematurity increases the risk for various issues for the neonate, including neonatal respiratory distress syndrome. So the hope in tocolysis is to give time to give corticosteroids to promote fetal lung maturation. Now, what is surfactant for? Basically, keep the alveoli from collapsing when, after you've exhaled, they've gotten small. So one of the main lecithin constituents of surfactant is DPPC, short for dipalmitoyl phosphatidylcholine. Dipalmitoyl phosphatidylcholine, DPPC. Synthesis of surfactant starts around 20 weeks gestation, and mature levels aren't reached until about 35 weeks of gestation. So you can see that if we're preterm, the fetus could be in danger of lacking sufficient surfactant. Since lecithins are a major component of surfactant, if we did a ratio where lecithins were the numerator, it would make sense that we want the ratio to be a higher number rather than lower. I don't think they take an amniocentesis anymore for assessing fetal lung maturity, but questions about lecithin sphingomyelin ratio may still show up on STEP. So the lecithin sphingomyelin ratio, the LS ratio, in amniotic fluid, we want it to be at least 2. And we would know we're in trouble if that ratio were under 1.5. So preterm labor, give tocolytics, give steroids to mom, which might help surfactant production. Then also give exogenous surfactant to the neonate after they're born. In neonatal respiratory distress syndrome, surfactant deficiency means increased alveolar surface tension, which permits alveolar collapse, and that gives in turn a ground glass appearance of the lung fields. That is a uniform granular pattern. Not so much for step 1, but later for M3 shelf exams in obstetrics and maybe pediatrics, you'll want to keep distinct neonatal respiratory distress syndrome from something else called transient tachypnea of the newborn. The name states that the neonate is breathing fast, tachypnea, but also implies that the problem will go away soon. Could be 6 hours, could be 48 hours, mainly in cesarean deliveries, and it's due to delayed clearance of fetal lung fluid. So the newborn may be grunting, actually. Now, a newborn with NRDS may need therapeutic supplemental oxygen because their alveoli are having such a hard time keeping from collapsing. Unfortunately, this oxygen, therapeutic oxygen, can trigger or exacerbate some other complications associated with prematurity. The two major themes I see in these 3 pathologies that I'm going to mention are number 1, issues with vascularization, and number 2, oxygen toxicity / free radical injury. So I'm going to mention the 3 complications by name and explain their names, but not much else at this time. They are retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. These may show up on step 1, but also definitely you need to know these later during M3. Bronchopulmonary dysplasia. Of course, you know dysplasia is bad formation, and pulmonary refers to the lungs, and adding broncho onto that seems to emphasize that it's not just the lung parenchyma, but also the airways of the bronchi and maybe bronchioles. We should acknowledge that in trying to treat neonatal respiratory distress syndrome with supplemental oxygen, we may in fact be trading up for a different lung pathology. We treated the lungs for one problem and now got a new lung problem in its place. Bronchopulmonary dysplasia is about free radical injury from oxygen, a concept you know from reperfusion injury when treating myocardial infarction. Then we have neonatal intraventricular hemorrhage. So the newborn has an intraventricular bleed, but which ventricles are we referring to? The ones in the brain. So somehow the vasculature in the brain suffers damage, resulting in a brain bleed. And then we have retinopathy of prematurity. So the premature newborn has some kind of problem with their retinas. Depending on where you are in your studies, this might be obvious, but when I started M1, when I would hear retina, I would be like, yeah, cool, some part of the eye. So let's be sure that we are thinking of the sensory part in the back of the eye, as opposed to, say, the lens, which is sort of just the window in the front. Basically, I'm asking that you acknowledge in your mind when you hear retinopathy that it sounds a bit more threatening, that's all. Retinopathy of prematurity is about free radical injury by oxygen and also entails abnormal vascularization. Later, when you learn something called wet age-related macular degeneration, you might find some similarities between that and this retinopathy of prematurity. Although from the age-related part of the name, clearly wet macular degeneration should be more about older patients. And the macula is indeed part of the retina. It's a little spot near the center for central vision, color vision, fine detail. Finally, for this theme of radical damage involving oxygen, let's recall that oxygen is the final electron acceptor in the electron transport chain. Also, neutrophils and macrophages lyse pathogens that they've endocytosed using something called oxidative burst. So you should have a strong association of oxygen with lone electrons and radicals. Oxygen is a powerful substance in biological systems, and that does include the ability to cause damage. Okay, let's tie it all up. Lecithins are a main component of surfactant, and DPPC, that is dipalmitoyl phosphatidylcholine, is one of the main types of lecithin in surfactant. Surfactant is necessary to decrease surface tension and keep alveoli from collapsing on expiration. Side note, saccular stage of lung development happens to be from week 24 of gestation up until birth. Alveolar stage, on the other hand, is from week 36 all the way up to 8 years of life. Synthesis of surfactant starts around 20 weeks gestation, and mature levels aren't reached until about 35 weeks of gestation. In amniotic fluid, higher lecithin sphingomyelin ratio is generally better, lower is generally worse, under 1.5 is bad, 2 or higher is good. Any delivery after 42 weeks is post-term or past due. Babies delivered before 37 weeks are premature. But delivery before 37 weeks, that is prematurity, is associated with low surfactant as well as lung underdevelopment, in particular, neonatal respiratory distress syndrome. If labor has started and we are preterm, we give tocolytics and corticosteroids. One tocolytic is terbutaline, which is a beta-2 agonist, trying thus to decrease uterine tone. Indomethacin is an NSAID that can be used as a tocolytic, and nifedipine is a dihydropyridine calcium channel blocker that we can use as a tocolytic. Steroids are given to promote fetal lung maturation. The preemie baby, when delivered, is also given exogenous surfactant. In the case that the newborn does indeed have neonatal respiratory distress syndrome, alveolar collapse will give a uniform granular pattern in the lungs, in the lung fields. That is, a ground glass appearance. Therapeutic supplemental oxygen can be given to treat these cases. However, this opens up the possibility of several complications due to both 1, problems with vascularization, and 2, free radical injury, which should make good sense in relation to oxygen. The complications are in the eye, brain, and lung, namely retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. Do you know who Stevie Wonder is? The singer, songwriter, musician. He supposedly had retinopathy of prematurity. Okay, that's it for this one.